Now we'll move on to the sixth presenter, Dr. Karunakar from Usmania General Hospital, Hyderabad.
Good afternoon, judges. First of all, I would like to thank the organizers for selecting our CD presentation to be presented here. And also I would like to thank the superintendent and head of the Department of Cardiology and head of the Department of Surgical Gastroenterology, Usmania General Hospital. This case was done in April 2012 by Professor Dr. K.M. Reddy in Usmania General Hospital. So, Mr. Ravi, 33 years old male, laborer, resident of Kazipet, Warangal district. He was chronic alcoholic, presented with complaints of pain abdomen, hematemesis 4 to 5 episodes, melena, and fatty stools for the last 1 year. He was non-hypertensive, non-diabetic. On examination, he has mild icterus, no pallor. Hemodynamically, patient was stable. His cardiovascular system examination and respiratory system examination were normal. Per abdomen, there was epigastric tenderness present, but no organomegaly. He was investigated, and his routine investigation found to have CBP, urea creatinine were normal. Serum electrolytes were normal. He has elevated serum total bilirubin of 4.2 mg per deciliter, and also he has elevated serum amylase of 182 international units. And his PTINR was normal. CTBT, HIV, HBS, AG was normal, and ECG within normal units, 2D echo done, which was normal. His ultrasound abdomen showing liver of normal size with mild increase in echo texture. Pancreas atropic, evidence of well-defined heterogeneously hypoechoic thick wall cystic lesion of size 6.3 into 6.1 centimeters with internal hypoechoic cystic lesion and multiple peripheral calcification noted in the head of pancreas, which is suggestive of chronic pancreatitis. Impression was atropic pancreas with well-defined heterogeneously cystic lesion noted in head of pancreas with grade 1 fatty liver. Possibilities of chronic pancreatitis with query aneurysm of common hepatic artery, query pseudo-pancreatic cyst. With that, the patient was advised to undergo CE abdomen, he underwent subsequently, which was showing pancreas in decreased size with altered and decrease in attenuation with multiple parenchymal calcifications, as well as evidence of well-defined heterogeneously mixed density lesion of size 8.5 into 6.6 into 6.3 centimeters is of large cyst noted in the head of the pancreas. Lesion shows thick wall with multiple calcification of the wall. And also post-contrast study shows central luminal enhancement with non-enhancing heterogeneous hyperdense peripheral crescentic thrombus. The lesion is stretching portosplenic confluence causing extensive compression over the IVC. So impression was chronic pancreatitis with aneurysm of common hepatic artery at the head of the pancreas and porta hepatis with peripheral crescentic non-enhancing thrombus causing extensive compression over the IVC. Stretching splenoportal confluence with collaterals at periportal areas. This was a CT, contrast enhanced CT film showing contrast enhanced lesion in the head of the pancreas. So with this, with the above history and clinical presentation, patient referred from Warangal to the Usmania General Hospital, was admitted in surgical gastroenterology department, and subsequently referred to us for possible identification and embolization of the bleeding artery. So here we have a little bit review of the celiac trunk anatomy. So celiac trunk is a major ventral branch of the abdominal aorta, arises at the level of upper border of L1 vertebra between T12 and L1. So it immediately trifurcates into splenic artery, left hepatic artery, and common hepatic artery. So this common hepatic artery runs to the right, and it takes a superior turn. There it will give us a branch called gastroduodenal artery. After that, it's known as proper hepatic artery, which is again divided. So gastroduodenal artery gives up branches to the head of the pancreas to the superior pancreaticoduodenal artery, and it will give branches to the duodenum to the supraduodenal arteries and continues as gastroepiploic artery. So we have planned celiac trunk angiogram done through the right femoral approach using JR4 guiding catheter, and this was a celiac angiogram which was showing the bleeders from the gastroduodenal artery there. So we have visualized the gastrointestinal artery bleeders and guide wire crossed across the bleeding point, crossed with the balloon support. This is a guide wire, and this is we have crossed the lesion. And subsequently, microcatheter is hooked over the guide wire, just proximal to the site of the bleed. Then we have injected with the gel foam. This is after injection of gel foam, we have withdrawn the microcatheter and checked there was no bleeding. And this is the final angiogram of the celiac trunk with no evidence of any bleed anyway. So hemostasis achieved, good result, no procedure complication. We have 4 months follow of this patient. He is doing well without any further episodes of hematemesis or melena. And we have reviewed the literature. Similar types of case previously done by interventional radiologists. Very few case reports were there. Thank you.
Okay. Thanks, Dr. Karunakar.